Okay. Right, I'll start anyway. So my name's Alicia. I'm one of the academic medical oncology trainees at the Christie, and I'm chairing this session looking at the comprehensive management of cancer of unknown primary in the era of personalised medicine. I'm going to do my best to keep time so that we're not all late getting out after this session. First up is actually an audio of a patient who has cancer of unknown primary.
To be told cancer is one thing, and then to be told they can't find it, I couldn't process it at first. I thought, well, you're doctors, you've got to find it. It can't just appear. And when they taught me through cancer unknown primary, you understand it more. Up to the January, I didn't know I had cancer. Now, I've had it since September. I might have had it longer than that. But because you don't know, and you're in denial, because you think, well, it can't be me. I haven't got cancer. I'm pretty all right. I'm fit and healthy. I'm eating well. I'm drinking well. I'm all right. And then the bombshell comes in the January. You've got cancer. At first, it knocks you, and then you think, all right, then I'll beat this. And then they say to you, it's cancer unknown primary, which is quite an unusual cancer. And the care I've had from the diagnosis in the January to today, it's been fantastic. You know, it's like, oh, okay, let's it's it head on. It's not like you said before, breast cancer, prostate cancer, liver, lung, because you can remove things like that. With cut, what do you remove? Where do you start? What do you do? You know, it's like anything. You know, if you've got a water leak coming through your ceiling, you can bodge the water leak up so it don't come through again, but it'll come somewhere else unless you get to the source. Now, the sources, you don't know. Dr. Cook, who's my doctorate in the clinical research facility, she explained everything at the start. Dr. Scott was with her at the time, and she explained it to someone who doesn't know anything about cancer. I fix cars for a living, that's all I do. But she explained everything that I could understand. And I know it's a bombshell when you get told you've got cancer, but it's also helps when they explain it to you in layman's terms. It was dead easy the way she said, the process, this is what you're going to go through. Hopefully, if that don't work, we'll try this. And it was just very easy to manage my emotions, being talked to like I'm a human being. I weren't just a patient, I was a human being. And it helps massively in your headspace. You don't know the end of the tunnel. You don't know. But as long as the doctors can speak to you and be truthful with you, it's half the battle. So it's all about time. And that's the thing, that's the only change I could have done changing is the time scale. If you would have just condensed it into a few weeks rather than months, then I don't think the outcome would have changed. I think it's still cancer unknown primary if it's a year down the line. But like I say, it's only the time scale that I can not complain. Complain's a bad word. It's change, really. Talking is a massive help to different people because some people don't want to talk. Some people just want to sit there, be left alone. And I get that, but a lot of people do want the comfort of talking. Everyone has bad days. Everybody, in all walks of life. You wake up one morning, you've got a bad day. You know, no matter what bad day the nurse, the doctors have got, they do the best for you. And there's nothing really you could say to improve anything. There's nothing. Just keep doing what they're doing.
Okay, so I think Lee really summarises the challenges that patients with CUP have, and they are a unique patient cohort, and we're a really important part, the acute oncology team, of the first start of their journey. We know that most patients with CUP present as an emergency, so that's the start of their journey, and as he said, it's usually long and time consuming with lots of uncertainty. So we're going to cover some of that in the session today. And we're going to start with Dr. Claire Mitchell, who is a consultant in medical oncology at the Christie, who's going to talk about the CUP patient journey in Greater Manchester.
Hi, so it's great to see everybody. It's been a little while, I think, since we've had meetings like this, it feels like. So it's lovely to get everyone in a room and nice to see some familiar faces. So let me move on. There we go. So as Alicia says, I'm Claire Mitchell. I'm a medical oncology consultant at the Christie. I also do acute oncology at MFT, covering MRI in North Manchester. And I treat patients with CUP, essentially, at the Christie. So I sort of see them perhaps at the point of diagnosis through acute oncology, but then I also see patients a bit further down the line where we're thinking about treatment and what treatment options we have for them. So I'm hopefully going to give a little bit of an overview of the patient journey and throw in some updates as to things that have been happening. So you're probably all aware of this, but just to recap on CUP, really. I mean, as Alicia just alluded to, it's a very heterogeneous kind of mixed bag of patients. We've got patients who present so many different symptoms through different presentations, come through different services, and that in itself is one of the challenges with CUP. It's not straightforward. It's not like you've got a breast lump and you go onto your GP, they send you to a 2-week wait clinic, and hey, that's easy, isn't it? These patients struggle at that point of diagnosis because it's recognising those symptoms, even just recognising there actually potentially might be an underlying malignancy. CUP is the 20th most common cancer in the UK. This data is a little out of date now, but it's the most recent we've got. It accounts for about 2% of all cancer diagnoses. Incidence is reducing. That's probably because we are actually getting a bit better, I think, over time at actually diagnosing patients and understanding a little bit more about the way that CUP presents and how to pull out some of those other disease groups that might present in similar ways. I don't think it will go away completely, so hopefully I'm not out of a job just yet. But again, as we've already touched on, what generally happens with cancer of unknown primary is we see them presenting more frequently through the emergency route, so ending up in ED departments and presenting to acute oncology teams. And when you look at the common cancers, cancer of unknown primary, about 57% of patients will come through that emergency route. And then you compare that to, say, something like breast cancer, well, hardly any will come through the emergency route as their route of presentation. So that has a massive impact on a patient's outcome, because by the time they're presenting to an ED department, they're already unwell. They've got to that point where actually they've got, almost crisis point, and they've presented because they're symptomatic, they're unwell, and they need admission. And that impacts, therefore, on their survival and their prognosis. And this is actually true for any cancer that we have. If your cancer presents through an emergency route, you are much more likely to have a worse prognosis. So there you can see emergency presentations. This is for CUP, but essentially it impacts on, not only your 6-month survival, 12-month, later survival data. So how do we address this? What are the challenges? So the challenges, not just at diagnosis, they're throughout the pathway when it comes to CUP. So at the start, we have patients who often have maybe vague symptoms, perhaps symptoms that GPs might not easily identify as being malignancy. And that's through no fault of GPs. They're incredibly busy. They're seeing so much stuff. How do you pick out that one cancer, patient who might have cancer amidst the 10 patients you've seen who've all got back pain, there's one who might have cancer? It's a really hard task. And when GPs have concerns for cancer, we have these nice 2-week wait pathways. And if you fit that pathway, great, you get seen really quickly, but CUP doesn't fit into a nice pathway always. It's much more complex than that. So we struggle to get these patients to the right place for that immediate impact and that initial investigations. When we do get those investigations done, there's often a lot of confusion. It's people uncertainty. Where do we go with it? Now we've got a scan that shows cancer, but we're not quite sure. Things haven't quite developed perhaps to the extent that we would like. And one of the key things is that when patients are sort of almost passed between specialities, they often then don't get the support they need during that time. So there's all this uncertainty, and as the patient just alluded to, you don't know what's going on. That's scary, and everyone's telling you you've got cancer, but we don't really know what it is. And that whole support mechanism isn't there for our CUP patients. We then come to sort of further down the line, and we might go to an MDT. And now we do have our CUP MDTs, but again, there's quite a lot of variability still across Manchester and across England and further afield in terms of what CUP MDTs look like and how they function. At some point, we hopefully do get that confirmed diagnosis of CUP, and we hopefully treat our patients that are fit enough. But there's challenges in that as well. Research in CUP is more limited because it's a smaller disease group. It's quite hard to do research in these patients, and they're obviously not fit enough for a lot of clinical trials, so we struggle sometimes to do that. And that then makes it harder to make advances in terms of their treatment. Things like accessing targeted therapies, personalised medicine, all these things that we hear about for all the other disease groups, it's really hard to actually sometimes get those similar treatment protocols for our CUP patients. So we struggle. We do have a site-specific CNS, but again, that support is probably more limited for our patients. And that again, it's understanding and education for our support services also in the community, like Macmillan Services, who again are under pressure and are struggling, obviously, with the workload that they had. So it's again about education and training of people. And often patients who have CUP have delay in referrals, not just to oncology, but also to palliative care services. So when they do reach the end of life, sometimes all those support services and those conversations that maybe could have been had earlier feel very rushed towards the end. And they perhaps don't have the best experience, and their families and carers don't have the best experience. So we need to look at ways how we address all these issues. One other thing that perhaps doesn't sometimes help with CUP is the lovely definitions that we have. I sometimes think that actually makes the situation worse, because you're trying to almost fit people into certain things, and patients don't always fit neatly into boxes. But these are the definitions that are defined by NICE. So essentially the CUP pathway, I suppose, starts with a patient being diagnosed with MUO, which is malignancy of undefined origin. And essentially what that means is the patient's got evidence of cancer either clinically or on a scan, but we haven't really done any more than that. We've just found a starting point. And then as you move through that diagnostic process, you come to the point where you may become a confirmed CUP. And I suppose we need to view confirmed CUP as we would at any disease-specific group like breast cancer, lung cancer. It is a diagnosis. And we're still, I think, struggling to get to the point where people actually recognise that as a site-specific diagnosis. One thing that may help, and I'm hoping will help a little bit, is the development of our rapid diagnostic centres. So these are now becoming more established across GM. I know there's many areas now that have access to this. And essentially, rapid diagnostic centres were developed to help improve our referral pathways. And the ACE pilot project that was done in Manchester looked at vague symptoms, but CUP kind of fell under this as well. And what they found was that they had a pickup rate of about 8% of cancer for patients who were referred by GPs into rapid diagnostic centres. So these centres essentially meant to be like one-stop clinics. Patients can be referred in, have a CT scan done, perhaps endoscopy, depending on how the clinic's set up, easy access to biopsies, and then hopefully a diagnosis. And that happens in a defined time frame, literally like a couple of weeks, not the months that we sometimes see for some of our patients. So the vision is this single sort of point of access for our patients, like replicating what a 2-week wait pathway looks for other disease groups, but having that for CUP patients, and allowing referral into rapid diagnostic centres, not just from primary care, but also looking at how they can support our emergency services, our acute physicians, because we often find that patients may have an incidental finding or are diagnosed on admission, perhaps don't need to stay in hospital, but we've got nowhere to put them. So they end up staying in hospital just to have a scan done or a biopsy done, which perhaps isn't necessary. So looking at those alternative ways that we can manage these patients. So these are sort of, let's say, just give an idea of what the rapid diagnostic centres look like. And hopefully this will improve the diagnostic process for our patients. As I say, they're being established, but there's a lot of work out there now. I think a lot of evidence to show this can work if it's done properly. And it's how to get that message out there to our trust that we can use these for MUOs, for CUP patients, and how we utilise and work with our emergency physicians, acute physicians in supporting this. So this is sort of the pathway that we kind of have at the moment. So essentially a patient who's an MUO might come to their GP or might present to secondary care. Hopefully a single point of access like the RDC. And that RDC, what's really important is a working relationship with the local CUP team and the CUP MDT. So they've got the support there, so they know where they can get advice from, support and discussion of a patient within an MDT setting. Some of those patients referred to the MDC may not have cancer, so they go back to their GP. Some may have a cancer diagnosed and it's a site-specific cancer, so like lung cancer. And again, obviously, they would refer to that pathway. And then the ones that we made a provisional CUP go through the CUP MDT so that advice and support can be given. And that's an important part of that is obviously also support for the patient. So having a key worker who can contact the patient, keep them updated, liaise with them so they know what's going on. Once the patient's been reviewed in the CUP MDT, then usually the outcomes may be out. This patient may not be fit enough or well enough for treatment, so perhaps we're going down the best supportive care route. If you've got a confirmed CUP who is a person who's well enough for consideration of treatment, referral to the cancer centre for treatment. And then for those patients where perhaps a primary is identified, making sure those patients are quickly seen and dealt with by that site-specific group so we don't get further delays in that patient pathway. So this map's a little out of date, but it's just giving you an idea of sort of the geography of Manchester, I guess, and where our MDTs are. But we essentially kind of have MDTs at all our acute hospital trust sites, although there's now been a bit of a merger, obviously, with the NCA, changes in MFT. Some of these have now become more sectorised models, and it maybe we look to that more, looking at sectorised model. But then we have the central CUP MDT for those confirmed CUPs. So I thought I'd just show you a little bit of data from our local CUP MDT at the MRI, which is scheduled weekly. It doesn't always need to happen because actually CUP numbers aren't huge. I think that floodgate that everyone worried about right at the start has never quite happened. But essentially this is pretty standard for a year that what we would see. So total of 86 patients for the year 2021. So this is also sort of COVID data as well. So taking that into account, for about 35% of patients, no cancer was actually found. So not all the patients that come through the CUP MDT actually get a cancer diagnosis. It can be benign. About half the patients actually were identified to have a site-specific malignancy. Most commonly, we get probably lung cancer coming through the CUP MDT, hematological malignancies. We get quite a lot of bone mets that are prostate cancer, so they kind of come and then we get them onto the right disease group. And then we have some patients who we don't, I guess, proceed with further investigation because their performance status perhaps isn't good enough, or they've got comorbidities, or actually a patient says, I don't want to have further tests done. I know I've got metastatic cancer, but I just want to be managed symptomatically. So we don't put those patients through further investigations if it's not going to change their management or they don't want that. And so that was about 9% of patients. So at the end of it, you've got left 2% of patients which were confirmed CUPs out of those patients. So it is small numbers from what we actually see. And those patients get referred on centrally then for consideration of treatment. So I thought I'd present this case because I think Catherine's still in the room somewhere. Catherine, you'll recognise this case because this has caused a headache, but it's been a challenging case I think we've had at the MRI that's gone on for several months. And I think it illustrates some of these challenges that we have. So this was a gentleman that initially actually presented back in August 2022. He was 78 years old and he presented with abdominal pain and weight loss. And he came in acutely and they thought he had diverticulitis, but they did do a CT scan. His symptoms settled, he actually went home. The CT scan initially reported as, yeah, it's all fine. But then a couple of days later, the addendum gets added on, oh, he's got some bone mets. The patient actually had recurrence of his symptoms, so came back into hospital. So that gave us obviously the opportunity to investigate him further. He had an MR spine done, which showed impending MSCC at T8, T9. We did his PSA, his myeloma screen, staging CT tap. We didn't identify a primary, and all his results came back normal. There was a discussion with our team at the Christie, the MSCC coordinators, as it was impending, and actually his neurological symptoms weren't too bad. We put him on some steroids. His symptoms actually improved, and we proceeded to get further investigation. So his only site of disease that we could biopsy was bone. So it was arranged for him to have a bone biopsy done on the 13th of September. And I'm sure you know for bone biopsies, it takes a couple of weeks to get results back. So it came back, it was inconclusive, basically. So we had to then have a chat with Salford because his other site of disease was basically his spine, and we couldn't do spinal biopsies at MFT. So he was transferred to Salford. So but at this point, we're into October. Okay, after presenting in August. So there was a biopsy done at Salford, L1 lesion, and unfortunately, again, a couple of weeks later, the result comes back and it was inconclusive. So we've still not got a diagnosis. We then request another biopsy, this time a CT-guided biopsy. But bone biopsies to get for us are really difficult, so that's why it takes so long. It's limited to MSK radiologists that do it. And so by this point, we're now in December. Another biopsy, and this time we get something, but it's not quite diagnostic. It could be inflammatory, it could be a lymphoid infiltrate. So we're still sort of scratching our heads. We can't say this man's not got cancer. It certainly looks like he's got cancer, but we still haven't got that definitive diagnosis. So we think, well, let's just repeat his CT scan. Maybe there's something else would have turned up, we can stick a needle in. So he has a CT scan done. There was nothing really new on the scan. The bone lesions were stable. We did a PET scan, and that showed a thyroid nodule. So we thought, oh, well, maybe that's it. So he has a thyroid aspirate done, normal. So no closer, and now in January. So we put another request in for a bone biopsy. And the bone biopsy takes place in March of this year. So August to March, we're doing really well here. Finally, we get our answer. We get a B-cell non-Hodgkin's lymphoma. During this time, the patient's relatively okay, PS2, stable-ish, but unfortunately at this point he actually does start to worsen. His performance status starts to deteriorate. He's probably now a PS3 in terms of his mobility. So he gets readmitted and an MR scan repeated, and he's now got progressive disease of his MSCC. So unfortunately he had MSCC at T10. Back on steroids, actually symptoms improved, not unsurprisingly with being a lymphoma, but he had some palliative radiotherapy to his spine. And he's now actually commenced on R-CHOP chemotherapy and is doing very well. He's mobile with a frame. His performance status is now back at 2. And it's a bit hard to see on the PET because the FDG avidity on the PET isn't great, but on the bone, what you can see essentially is a bit of increased uptake on the right-hand side, which is actually, I think that was one of the areas we biopsied, and it's improved on the most recent scan. So essentially, we've got a patient who pretty much almost had a 10-month diagnostic pathway. And that isn't that uncommon, unfortunately. And we do see these patients occasionally. And it's whether or not, one of the challenges I think in the acute setting is how far do you pursue something? When do you stop? And for this patient, we felt it needed to be pursued. He potentially was well enough for treatment. We potentially thought this could be a treatable cancer like a hematological cancer, so it was worth us pursuing, and he's doing quite well. So obviously that's one case. I just wanted to touch on what happens to patients when they come to the Christie for more specialist treatment. And for these patients, these are obviously the fitter patients, performance status 1 to 2, I would say, that we're thinking about giving treatment to. For those patients who aren't fit enough, we are managing them palliatively, but that can involve things like palliative radiotherapy, obviously good supportive care, and making sure their symptoms are well controlled. For those patients who have more favourable prognosis and are fit enough, we can consider options like standard of care, which now includes whole genome sequencing. We've got SACT, obviously, our chemotherapy. We've still got our options like radiotherapy, and we even have some patients where we've actually gone down surgical routes for them. We have access to clinical trials. The COPISCO study is now closed, but hopefully we'll be reporting at ESMO in September, October. CUP-COMP, the first phase has now closed, but hopefully we will be looking to get more funding for that, and that will open. And CUP-COMP essentially is a translational study giving access to liquid biopsies for patients, which has been very useful for a lot of our patients. And then obviously we have our clinical trial centre at the Christie. So what do we see through our MDT? So again, this data is over 4 years, 360 patients. And we essentially review all our patients, both pathology and radiology. And the reason kind of for this, hopefully is explained with the results that we see, is that of all the patients we get, 50% we confirm as being CUP, but actually for about a quarter of patients, we diagnose a site-specific diagnosis, and that makes a huge difference for the patients. And for the other quarter, we have a presumed site-specific diagnosis, okay? So actually, that central review sometimes can, again, pull out those patients that potentially will get access to better treatment, not better treatment, but more site-specific treatment. And this just shows the impact that this has on their outcomes, okay, in terms of overall survival. So you can see a clear difference there. We know this, and this is now also being incorporated to our ESMO guidelines, which were done in January 22. So these are now being updated. And if you look, what we really want to be doing is identifying these specific subsets of CUP. They're the patients which will really do better if we identify them and get them to site-specific groups. And that's why we need to kind of get that message out to our MDTs, not just our local CUP MDTs, but all of the MDTs across GM, so that they're aware this does make a difference. If there's a possibility this could be lung cancer, treat it as lung cancer in a way. If it's colorectal cancer, treat it as colorectal cancer. The patient will get a better outcome. And then very briefly, I touch on genomic profiling, because obviously this has come in, and NICE have just updated their guidelines, and I think they're just looking at review at the moment. And essentially, it's incorporating things like genomic profiling into the management of our patients. This is really challenging in CUP because essentially to do whole genome sequencing, you need a fresh frozen sample. And that's obviously challenging in a DGH setting. You know, there's a logistics around that, which is really difficult. So there's going to be that sort of debate, I suppose, whether we do that within the DGH or whether that perhaps is a more specialist thing, perhaps at a cancer centre. The downside to doing it at the cancer centre is you're going to need to repeat biopsies, and that could potentially cause further delay for starting treatment. So it's not easy to introduce whole genome sequencing, but it's a conversation we need to be having and thinking about, although it may be that liquid biopsies actually will negate the need for this, but we shall see. And what does that mean in terms of treatments? Well, for patients where we identify abnormalities in the genomic profiling, we can hopefully access targeted treatments for them. And again, that can make a difference for our patients. It's not easy to get targeted treatments at the moment in England for patients where we do identify abnormalities, but we can do it through clinical trials or compassionate access. And this is a very brief case of a lady who actually benefited from that type of approach. So this was a 53-year-old lady who presented with hypercalcemia, who had extensive liver mets, but only had liver disease. And her biopsy showed an adenocarcinoma, and it was very poorly differentiated. And we couldn't say for certain that this was an intrahepatic cholangio, but we had a feeling it might be. She actually went on the CUP-COMP study, and we started her on for an initial treatment with generic sort of cisplatin gemcitabine chemotherapy, but when her profiling results came back, it showed an FGFR2 rearrangement, and that is in a way helps us push the diagnosis towards a cholangiocarcinoma. And so her care got transferred to the HPB team because that will give her better access to treatments in the future, including targeted therapies. So again, it's important that we look to see how we develop these techniques for our patients and provide access to them. So that's it. I probably went over. My conclusions are there. I mean, I guess it's ensuring that CUP is part of the conversations and we're thinking about the pathways for our patients to make sure we continue to improve on the outcomes that we get for our patients. Thank you.
Thank you, Claire. And we'll take questions at the end of the panel discussion. I know that probably will have generated a lot of discussion. And the sequencing bit feeds in nicely with our next speaker, Dr. Helen Schlecht, who's Principal Clinical Scientist at the Manchester Genomics Laboratory.
Hi, thanks for inviting me here today to speak. So I'm Helen Schlecht and I'm a clinical scientist working at the Genomics Laboratory in the Manchester Laboratory. So I'm going to talk to you a little bit about whole genome sequencing for the cancer of unknown primaries. So in the last 10, 15 years, but particularly in maybe the last 5 years, genomic testing's massively accelerated. We can get so much more information on tumour cells from their genomic profiling. And partly this has been driven by whole genome sequencing. So whole genome sequencing allows you to look at the genomic profile of the tumour in the broader context of the whole tumour, not just the specific gene that you previously may have looked at. It allows you to maybe classify diagnostically where that tumour is, what that tumour is. You can look at genomic signatures, and that's the sort of thing you can only do by looking at the changes across the whole tumour in multiple genes and multiple areas. It can identify germline susceptibility genes and many other things, target treatments. It can be used for research, and it can use to drive our understanding for the future of tumour and cancer treatments. Where did this come from? So a number of years ago, we embarked on the 100,000 Genome Project, and this led to the reprocurement of genomic services across England. We built and developed a number of genomic laboratory hubs and genomic medicine services. And alongside of that, we did a huge project of whole genome sequencing in both rare disease and cancer. This is us. England is divided into 7 regions with regard to genomic services, and we're part of the Northwest region, and the Northwest Genomic Laboratory Hub is where I work, and this consists of a number of laboratories working together to deliver genomic testing for the whole of our region. It also led to the development of the National Genomics Test Directory. So there are 2 of these. There's one focused on rare disease, the other one is focused on cancer. And these set out to outline the key targets that are needed in genomic analysis for a variety of areas, including a huge variety of tumours. And the aim of it was to lead to equality of genomic testing across the country. So all patients should be offered the same genomic profiling regardless of where they live. It's a bit small, you might not be seeing, but cancer of unknown primary is on here. There we go. So cancer of unknown primary is on there. There are two main targets listed here. One is whole genome sequencing. The other is the NTRK fusions, which have recently been licensed for any tumour type. But there's an additional category where this type of tumour can also fall under, and we're able to do whole genome sequencing on any solid tumour that's exhausted standard of care options. So whole genome sequencing as a routine test was introduced for cancer probably about 2 years ago through the Genomic Medicine Services. These are the eligibility criteria currently. We started looking at sarcomas, paediatric tumours and haematological malignancies. We then moved on to look at CUP and these solid tumours of which have exhausted all standard of care. And now we're also looking at high-grade serous ovarian and triple-negative breast cancers. So all of these tumour types are eligible for whole genome sequencing through the Your Genomic Laboratory Hub. So how do you do that? How do we access these tests? What are the practicalities and also the challenges? The histopathology side of it in terms of cancer is still really important. We need to understand the phenotype, the histology of the cancer before it goes through to genomics. Genomics information is only useful in the context that you have with that histology, with that phenotype, with the patient's background. And that allows us to do the interpretation and also to look for the right things. The whole genome is a huge thing. We cannot look at everything. You would not be able to interpret everything. You need to be able to know what to look for and interpret it in the right context. So this initial data is really important for the whole genome sequencing. What do we need? As we've mentioned in the previous talk, and one of our biggest challenges, that currently whole genome sequencing can only be done on fresh tissue. We have some guidelines on how big that tissue can be. Actually, you don't need a huge amount of tissue when it's fresh, but it does need to be fresh, which is a huge challenge in terms of transport, in terms of archiving. The majority of our tumour tissues are stored as formalin fixed. We need to have evidence of neoplastic cells within that sample, so we do ask that that assessment occurs before the sample is sent off. It can be done on a mirror block or an equivalent, but whilst we do assess it again during sequencing, it is really useful to make sure we understand there are tumour cells within that sample. As I say, it can't go in any form of fixative. It needs to be sent with priority within minimal time. So we say ideally if the sample is taken fresh and sent to us within 72 hours, it can come refrigerated or cold or at room temperature, as long as it's not exposed to anything extreme and it gets to us within that 72 hours. The DNA which we extract from it is very, very stable. However, there are options to store these samples. If it does need to be stored for longer, it can be frozen, but it would need to be frozen pretty quickly within 2 hours of being extracted. And then those samples can be stored frozen until any testing is required. In addition to the fresh tissue, we do need a germline blood sample. The whole genome sequencing for cancer can only occur with those matched samples of germline and tumour. It's new to many people, but there's a huge amount of information out there. There are information leaflets for people wanting to consent and talk to patients about whole genome sequencing. There's also a huge amount of information out there for patients on whole genome sequencing. What does it mean? Unfortunately, it comes with paperwork. So if you can get hold of the samples, we unfortunately do need quite a bit of paperwork completing. We have a form which accompanies the samples. Obviously, to keep track of those samples, make sure they get booked in the right way. We have to have a test request form, which is this form on the right. This gives you that patient background, that patient information, identifies exactly what tumour type it is, and any additional information which will be useful for the interpretation. And then we also need this record of discussion. So this is the consent and the acknowledgement that the patient and the testing that is being done has been discussed. Whole genome sequencing is slightly different to your standard routine workup in a pathology lab or your targeted testing. So there is an element of patient discussion that needs recording. But again, there's a lot of information and support out there and around for this to be done. So what do we get back? A whole load of information, as I said. So this is the kind of data that would be received back to your genomics laboratory. We've got small variant information, so we've got genes and particular changes. Some of those we'll be very familiar with. We'll know whether they're likely to have an impact. Some of those might be drug targets. We get information about the genomic profile, so are there any copy number changes, structural rearrangements, fusions between genes? We'll get information about what we call a mutation signature. So we look across the whole genome. Does it look like a homologous recombination deficient tumour? Does it fit with a mismatch repair tumour? Or does it, like this one, fit with tobacco smoking? There's a huge number of profiles you can pick up from that data. And then we get these nice, pretty circular plots, which that's your whole genome broken down into chromosomes. You can look at copy number loss, gain. You can look at rearrangements between chromosomes in a much more visual way. And with CUP, this genomic information can be really powerful, really useful. You've mentioned in the previous talk how if you can identify the site, that's really important and can be really useful. And some of these genomic markers do give you that information. You can have genomic markers which have a pattern that are so consistent with a primary of colorectal or lung cancer, we can say that it's likely that's the primary of origin. Or it might just give you a target that is treatable using current treatments or clinical trials. A lot of the fusions, NTRK and FGFR are some of the current, most recent ones, but that information would all be available here. It is a lot of information and it is relatively new. The pathways are complex, but there is a huge amount of support and investment into enabling this testing for patients. The sequencing data, as I say, that huge amount of data is quite baffling, but that will only come back to the laboratory. We have trained clinical scientists to interpret that data. They will do that initial primary analysis. They will look for the key interesting factors, findings in that whole genome. And then we have a genomic tumour advisory board. So we meet currently fortnightly to discuss all our whole genome sequencings. And the information that we get back from the whole genome sequencing will be presented. The key findings, the interesting findings can be presented and then discussed with oncologists and pathologists in the context of that particular patient. And then we can issue a summary report of those findings following that GTAB. And those GTABs are open to anyone, not just people involved in the patients. They're there to support, and they're also there for education. They're also there because this is a new service and we do want people to be able to access the information where they would like to. As I say, there's a huge amount of resources. Our website, the Northwest Genomic Laboratory Hub website, has a lot of links out to information, but it also has all those key request forms and sample requirements, the key information you need if you want to refer for whole genome sequencing. Those are the forms. And then, as I said, in summary, there is a lot of support out there. There's a lot of focus on whole genome sequencing. There's been a lot of discussion about whole genome sequencing for CUP. And then moving on to the ctDNA analysis, this liquid biopsy, which is kind of a similar, it's looking for huge numbers of targets, but using liquid biopsies, which potentially are going to be more useful for CUP patients because of the challenge of fresh tissue. The GTABs are there and they are open to anyone who wishes to attend. If you can't access fresh tissue and FFPE fixed tissue is your only option, genomics is not impossible. We have a huge number of large targeted panels in the laboratory. We can do fusion panel testing. We can look for a whole range of targets. It helps if you've got a suspicious of something, but we are able to look for certain genes. We can look for a whole panel of genes. And that is all optimized on formalin fixed tissue. So whilst whole genome sequencing is incredibly useful, if you can't get fresh tissue, it doesn't mean genomics is impossible. So thank you for listening, and there's some contacts on there if anyone wants any further information. Thank you.
Thank you, Helen, and a little bit under time, so that's good for our getting away on time. So the final speakers are Kerry Nair and Anne Crook. They're from the Psycho-Oncology Service, and they're going to talk about the psychological support needed for these patients.
It's a little bit of a change of direction from all that science. I'm kind of quite blown away by all of that science. So it's a little bit of a change of direction, this presentation. I don't know if you want to just collect together any of your thoughts of questions for the last two speakers, because I'm going to take you on a bit of a different direction, but just give you a minute. I don't actually know how to work. Do I just press the top button? The arrows. Okay. So yeah, a bit of a change of direction. So thinking a little bit differently now about psychological support for your patients, and particularly with the focus of today, with the uncertainty of a CUP diagnosis. We've been asked to speak, so thank you very much for inviting us. This is the last presentation. You're on the home straight now. So my name's Kerry. I'm one of the counsellors in the psycho-oncology team at the Christie, and I'm here with my colleague Anne. So we've been asked to kind of talk with you today really about what you might be thinking. And our messages today really are, I don't think we're going to tell you anything new about psychological support. The work that you do and the feedback that we get from the patients that we see in our clinics is that actually they rely on their treating teams. They find fantastic support from their treating teams. And you're probably doing a lot of this work anyway. So I'll give you a couple of key messages to take with today, but most of it, I don't think I'm going to tell you anything new, but we'll just sort of bit of a refresher really, or something at the end of the day. So I'll talk a little bit about cancer-related distress, what we mean by that, a little bit about how anxiety perhaps is even more increased in a CUP diagnosis and what the research tells us, the psycho-oncology research tells us. And as their clinician, the people that I'm talking to here today, what to consider and what to offer your patients, and when to refer on if concerned. So cancer distress, what we really mean by that, and I quite like this definition, it's an American definition, but what we mean by that is an unpleasant experience of an emotional and a psychological, a social and spiritual nature that people experience, and it interferes with their ability to cope. And particularly perhaps interferes with their ability to cope and engage with cancer treatment. And it extends along a continuum from common normal feelings of vulnerability and sadness and fears to problems that may affect their functioning, their mood, their kind of more severe kind of trauma end of the spectrum. It may end up in manifesting as depression, anxiety, panic, and feeling isolated or in a kind of spiritual crisis. And people affected by cancer or any kind of significant health diagnosis, we think with them really a lot about loss. So our assumptive worlds, those of us, all of us sitting here today, those of us with health diagnosis or not, our assumptive worlds, we define as the world where we understand who we are, we understand how the world works, we understand what keeps us safe. And when people have had a significant health diagnosis, that dramatically changes. So we think with our patients about loss, really, loss of the assumptions that we make in the world about ourselves and the world around us. And a quote here from somebody I worked with, and I hear this a lot, you can't go back. There's no return back to the world before, really. So often our patients use words like grief, or they're using words that we then name for them, a bit like a grief response to this loss of this assumptive world. And so they're very much in a grieving process. They're presenting with lots of anxiety and low mood and traumatic symptoms, but they're in a grieving process. So we think with our patients, and I guess this is what you do too, really, So think about grief being a normal and natural response to a loss. It is an adaptive process that helps us integrate loss and changes and transition into our lives. And it may be painful, and it will be painful, but it's part of a healing process. It's not necessarily a pathology. So I guess you won't be able to read this, but it is something that we use when Anne and I and the team talk to the people, to the treating teams at the Christie. We talk about this continuum of distress, and we help the senior nurses and our colleagues really at the Christie to think perhaps where their patients are on this continuum. So this kind of end here, sort of healthy, reacting, sort of normal grief process. And these slides are available, I understand, so you'll be able to look at this distress continuum without trying to kind of write it down. But this far end here is kind of a normal, typical kind of reactions that people might experience. And then I'll talk a little bit more about this far end here, which is maybe perhaps the end where you might want to be thinking with your patients and their families about maybe they want some extra support. So this is just some statistics here about depression, anxiety, and trauma, really, that we'd expect in cancer patients. And then Anne and I went through, when we were preparing this presentation today, through some of the psycho-oncology research, and we found a couple of papers, quite relatively new papers, around particularly treating CUP patients and what psycho-oncology research tells us about. So this study, which is from this is one from the BMJ, which talks a little bit about actually what's particularly difficult for CUP patients. So particularly challenges around making sense of the uncertainty, what Dr. Mitchell referred to in her patient, and that patient story that we heard at the beginning of today, which was talking about that uncertainty, sitting with that, both with their treating teams and then at home with their families, just sort of the not knowing and raising the anxiety with that. And then making sense of all that kind of process, which, as you said, Dr. Mitchell, is sometimes longer than for these patients. And the other piece of psycho-oncology research that we found from 2022 from Australia, the two patient groups that particularly find this even more challenging, really, young people and those who are experiencing particularly difficult to manage physical symptoms as well. So I'm sure you're probably aware of these kind of particularly flashpoints in patient journeys where distress is higher. So I won't go through all of this slide, but it's available there to look at. I'm sure this is what you're aware of in the work that you do, particular key points. And then to kind of end with, as Anne and I were preparing this presentation today, our key messages really is that you're probably doing, or you're doing day in, day out, and we hear this from our patients really, is they really hang on to their treating teams for the support that you give them. And you will be doing probably more than you think with just being with this distress, noticing and naming the uncertainty, normalizing that uncertainty and normalizing that distress, and allowing that space, as that man at the beginning talked about, that what he really valued in the people around him was just having some space and time and the people around him to kind of bear witness to his distress and his worries and his anxieties. And then lastly, just to say about when to refer on, really, so that on that distress continuum, the two boxes at the end, this is an American language again, isn't it, Anne? They're sort of injured and ill, which we're not quite so keen on, but we're using it because we're referencing a other model. But particularly when you're seeing people where their functioning is really impaired, so they're really not managing day to day, the mood is particularly low and really affecting their lives. Anxiety, particularly hyperarousal, perhaps sort of trauma symptoms might be kind of very prevalent for them. So they're the kind of people that you might want to think about maybe talking to your psychology teams wherever you're based, or if you're based at the Christie, talking to us about. And then, of course, there will be a small cohort of people who might need sort of psychiatric liaison as well, that you might want to have a think with support psychology and psychiatry support teams around you. So I think that's all from me today, and I'll kind of join my colleagues, and if you've got any questions from us after that. Okay. I think that's it.
Thank you. And I think we've had a really broad look at the whole pathway for patients with CUP, with all aspects, really. So I'd like to all the speakers to join us on the chairs for a panel, as well as Anne Allen, one of the acute oncology nurses from East Cheshire, and we'll answer any questions just in the last 10 minutes. So is there anyone with a question for the panel on any of the topics? Rachel.
Thank you. My question is, I guess it's for the whole panel, but just directed at the data that Claire presented on the number of patients referred through the CUP MDT who subsequently go on to have no cancer diagnosis. So my question is, do you think that the CUP MDT is being appropriately used by other teams, or is there scope to improve that pathway?
Yeah, thank you. Good point. I think there's certainly scope to improve the pathway. I think that's one of the challenges, though. Sometimes I think it probably varies across where you work, but in some ways the CUP MDT becomes a bit of I don't want to say a dumping ground, but a place where you could, if you're not certain and something doesn't fit into those neat pathways of everything else, it ends up in the CUP, and that in some ways is fine, because I guess it does give a home to those places, because otherwise where else would they go? But we probably do need to perhaps review those referral processes. And actually one of the key things in our referral processes is actually having the right information, because one of the difficulties we sometimes have is a lack of information in a referral actually then impedes your ability to give an opinion. So I think there is certainly room for improvement. Sometimes though, some of those cases, they are complex and difficult cases, and they do need to have that forum to be discussed in. And it's always obviously very nice for us to get a patient who doesn't have cancer, because we don't get to tell people that very often. So I think at the moment, it's certainly, I wouldn't change things, but it's something we probably could improve on and look at in terms of the referral processes.
Any other questions or thoughts about how the CUP pathway is in your area?
To ask Anne Allen, just to see from your end, how do you find the pathway is working? What are your challenges you face as a acute oncology member? And how is interaction with the other specialists in the central sites? Obviously, Claire is here with us. And last one, do you think it's realistic to expect that the whole genome sequencing will be rolled over to DGHs easily?
I think that depends on what funding each DGH has. At Macclesfield, we just have like a small MDT, which consists of myself, the radiologist, and an oncologist, and we haven't even got really any palliative care contribution either. And regrettably, we're just seeing inpatients, so we don't accept GP referrals, and we haven't currently got funding for a CUP oncologist. It does sit with Dr. Lavin, our colorectal oncologist, but she would just give an opinion at that MDT and would not usually follow patients up. But those that are deemed fit for treatment are referred to Dr. Mitchell at the Christie. It's just still not fully developed a proper CUP service, regretfully, at Macclesfield. So I can't really comment further. Yeah, I think we are, they have just got funding for a vague symptoms service. So hopefully we might cross-cover, things might help there. But until we get any consistent oncology support, I can't see that happening.
In case of genomic sequencing, do you think this will be feasible in your area?
I think until we improve the diagnostic side of things, it's like we experience at other trusts, it's that getting that rapid diagnostics, it's getting that tissue sample to begin with. And I think until that improves, I can't see that in the short term. Perhaps in the long term, once we get a rapid diagnostic service up and running, then maybe.
I just wonder on that thought, is if there's investment and funding in the rapid diagnostic centres, is this where we need to be funneling these patients and have it sort of centralised and then they're linked in with the genomics as well? But I had a similar question about the genomics in terms of we need to be identifying the right patients to have genomics, and I think we probably need to define that by what patients would actually benefit, and do they have the right prognosis to be undertaking the test?
Somebody has to make that judgment call, obviously, right?
Yeah, and that means and oncologists don't sit within the rapid diagnostic centres, so they wouldn't be able to make that. Yeah.
Can I ask a two-part question? One question is, what should the proper pathway be for those patients who present with brain metastases? So they present with neurological symptoms that is enough to get their head through a scanner. They've got brain mets. They have a CT thorax abdo-pelvis. There's either nothing there or something very equivocal there. Because as we sit there in the neuro-MDT, we quite often say local CUP-MDT. But often if these patients, as Claire highlighted, if it was one of the cases that she went through earlier, if that patient's been discharged home, which they often have, nobody owns them. Nobody, who do they belong to? Because in theory, we get, just biopsy the brain. But to biopsy a brain, that's as big a neurosurgical operation as completely removing a tumour. In fact, it's bigger because the risks are higher. And so biopsying brain mets isn't really a thing unless you've got absolutely no alternative at all. And so, like I say, we often sit in the MDT going, local CUP-MDT. So can you all just comment on that? And my second question was, the Galleri results have had a lot of press this week. Is that going to be a game changer in CUP?
So firstly, I guess to address that first issue, I feel that what we probably do need to look at is that single point of entry so that we can have patients getting the appropriate support. So I guess from my point of view, when at the moment, again, it's very hit and miss, but what I probably would like to see from my acute oncology services, when those patients come in with brain mets, that we can direct them to the RDC so they're sat within that, so they've got a place where they belong and know they belong and a point of contact. That doesn't mean that we're not going to be involved in their care. We will still be involved in their care and supporting the RDC. It's very important we are involved in that person's care, but then that potentially structures then that pathway rather than having these patients which actually just end up a bit everywhere and some of them you don't even know about. And they're the ones you really worry about, the ones you don't know about because you don't know who's supporting them, often nobody. So actually it's key to sort of trying to get patients all in one place so we can focus on that, give them the right support, get that pathway going. And then, they still come through the CUP-MDT. I still think that's appropriate because then we can advise, well, maybe we should be doing a PET or we can then assess the patient and give feedback. So personally, I think the RDC hopefully is an important step for us. We ourselves have looked at doing our own clinics, but it's almost like we're trying to reinvent a wheel that's already there. And when we've got a limited resource, do we need to have two services almost replicating each other? So because a lot of resource and funding is going into RDCs, I always feel like we have to jump on that bandwagon a little bit, but make sure that when these are being developed, we're involved and we're having the conversations because it's really important. The second point, the Galleri study. So I guess, I think it will be important. I think, again, the difficulty is because CUP patients are still don't have that single point of referral and they come through so many routes, that makes research more challenging as a group of patients. But again, if we can get that single point of access, I think that will actually make genomic sequencing a lot easier in our group of patients because we'll be able to structure it much better, select those patients, identify those patients, perhaps earlier on in the pathway, so we can get those investigations done earlier in that pathway for patients. So I think it's kind of linked in a way that we need that single point of access for these patients to get that pathway much more defined.
So, I think we've got time for one more. Yeah.
Sorry, it's just a quick one, really. I'm Lisa Cooper, and I've just this week gone back to the Christie as part of the acute oncology team, but my previous role was as part of the RDC for the Northern Care Alliance, involved in the setup, and that and I know that there are emerging RDCs across GM, but ours was the biggest and the first one that was set up, and our service sees over 350 patients a month. And I absolutely echo with what you said. I think the important things for RDCs are to be that single front door and the continued support for the patients, and also to link in really well with the acute oncology teams to say, what have we missed? What else could we do under our umbrella? When we've exhausted all our options was when we pass over appropriately to the CUP MDT. And certainly our experience of that in the RDC was that we saved a lot of patients, or we identified primaries that would have gone to the CUP MDT. So we're preserving that for the people who really, really need those complex discussions and in-depth management plans. So really, really important. And I absolutely highlight what you say about brain metastases as well, because we'd started to get some patients who'd got incidental brain metastases who were identified as an inpatient that were passed through our service. We held on to them. We tried to do all the diagnostics we could, and we tried to get them a primary diagnosis into the right team in the first instance. So there's definitely loads of scope to use RDCs to try to streamline those pathways and get people where they need to be as quickly as possible. That's all I wanted to say.
Thank you. No, that's really useful. So that's probably an output, isn't it? That the acute oncology service needs to link in with RDCs.
Your opinion from psycho-oncology point of view. I know we refer to you when somebody is really getting to the point, injured or ill, but should we be acting a bit earlier? Is there a scope to screen patients differently and refer before they get this kind of burden? Because prevention is better than cure, right?
I think two thoughts. Just before answering your question, Kostas, I think just what you were discussing about the patient pathway and RDCs, and maybe have a psychological professional located in the RDC to pick up the people who have got perhaps pre-existing mental health histories, because they're bound to suffer more and struggle more. And as you say, the earlier we can detect that sort of more vulnerable group of people for the psychological onslaught that's being challenged by, then I think the better. But sort of thinking about pathways, and as Kerry was sort of saying, the level of uncertainty for all people with a cancer diagnosis, but how that is magnified when people, well, I've probably got cancer, but nobody can really tell me yet, and there isn't any clear pathway for treatment. I think we all respond when we're feeling anxious to when we feel that anxiety is contained by the system or by the people that we can relate to. For those patients like Roy, the people who are looking after the patients. And so that sense of having I'm in a system and people know what they're doing, although they might not have the answers for me yet, is going to make an enormous difference. So even though I don't understand half of what you've been talking about in this session, although it is absolutely fascinating, just that sense of if the pathways and the systems work as well as they possibly can, that immediately will help the uncertainty that goes with the unknown, and hopefully to be known with the very clever genomics, etc. And I think all of that will help. But in terms of screening, it's difficult. The more screening you do, then it's kind of like, what resource do you have in place to be able to support people, which isn't a reason not to screen, but like all of the services, resource is an issue as well.
Okay, I think that's probably time for the questions. Thank you to all the speakers and to everyone's contributions. Thanks.
So, I'm in the sad position now to get to the end, although I think we are all tired now. So this brings us to the most important part of the day, which is the poster award, right? So I want some hands, or some voices. What do you think who won So any ideas? Somebody? No? This would be very biased, right? Okay, so I don't have any music for Oscar Awards, but I'm really happy to say that Claire DeMarco Massetti and her team won the prize for safe and effective outpatient management for patients with suspected low risk MSCC. And this is what I was promoting everybody to have a look at, because this can be rolled over to all of the sites. So congratulations. And I have here, I think it's 1 million, something like that, award, so I'll give that to you later. So we had really good attendance. 85 people joined us today, so I wouldn't expect anything better. Thank you all for participation. We had excellent speakers, MDT approach, so many different aspects were covered. I know it was heavy agenda, but it was a way to cover most of our themes in one session, and hopefully we'll be interested to do that again in due time. So important to provide your feedback so you can get the CPT points. I would like to thank, obviously, our patient representatives. Also, this is a very powerful piece of work that when it's presented, Sally Hall and Lee Young. Our chairs, Claire O'Rourke, Kalina Martin, Professor McBain, Alicia Conway, oral speakers and panelists. A special thanks to Gina Madera, Sophie Moore, Molly Pipping, and Nikki Jones, which actually without them wouldn't be able to do this nice event. And a special thanks to Jane, because without Jane I wouldn't be able to carry on all this nice piece of work. So we'll take the buying from Claire O'Rourke. So there are themes that will come out. So potentially around ambulatory care, virtual wards, and even collecting some data about immunotherapy. So yeah, obviously we learned a lot, but this generates more discussion and more work, unfortunately for some of you, Nikki. So yeah, we'll have some kind of more ideas coming through. And for those who haven't been tired enough, we have a drink later on after this one at Courtyard in the main hotel. So thank you all again, and have a safe trip back.